I'm Lee Kaplan. I'm the chief of the Division of Sports Medicine at the University of Miami. Very aggressive in meniscal tears and fixing the meniscus, and new technologies have allowed us to fix them arthroscopically, specifically within the arthroscopic procedure, doing everything on the inside of the joint. On occasion, it's important to do an inside-out technique where we make a small incision, but really the primary impetus in terms of our research and treatment is to fix and preserve as much of the native meniscus as possible. The more cutting-edge items that we're looking into now and that we're researching include meniscal transplants at an earlier time than were done 10 years ago for joint preservation. On articular cartilage, we're using the tissue banks using, instead of frozen, fresh cartilage to replace and regenerate the cartilage that's currently there. ACL reconstructions are primarily done arthroscopically now. The key is not necessarily what graft to use, but really the position of the tunnels. The tunnel positioning has changed by moving the tunnel a little more laterally and down the wall than it was in the past. So the techniques have changed, but yet the primary important factors remain to stabilize the knee. Well, we tried extremely rapid recovery, and patients are back running by 3 months. But really, with the advancement in physical therapy, it's not really the patient or how they're feeling. Now our limitation is really the regeneration of the vascularity of the graft. So graft maturation still takes about 6 months. So although the patients are getting better, a lot of research is being done currently on if we could get the graft to mature more quickly. Looking a lot at PRP, the growth factors really, when you add growth factors, they really wind up displacing within the joint very quickly, within seconds to minutes. What we're doing now is taking the patient's own blood and doing PRP and ACP and these different treatments to spin down their own blood and look specifically at if those factors given back from the patient's own blood can help regenerate tissue. It looks like it has a big effect not only on healing, but may have a big effect on pain. And in that regard, that's been very helpful. Bracing has gone in some ways very far, and in others it's still limited. We haven't been able to incorporate a brace yet that's strong enough to prevent ACL injuries. The problem is that as big as a lot of the athletes are and strong as their thigh and quadriceps are, no matter how tight you make the brace, the bone can still move. And if it moves several centimeters with a brace on, it's not going to help. In other terms, though, braces have been helpful. The Big Ten, for instance, has done a very good study where they've looked at bracing in athletes for medial collateral ligament injuries. So many teams brace the linemen.